16 minutes past 7, and waiting times across Scottish A&E departments have matched their worst level on record. The latest figures show just 66.2% of people attending hospitals were seen within 4 hours. The Scottish Government's own target is 95%. Well, Dr. John-Paul Loughrey is Vice Chair of the Royal College of Emergency Medicine in Scotland. Good morning to you, Dr. Loughrey.
Good morning, Laura.
How concerned are you about these figures?
Extremely concerned. I would say that this is easily the most challenging and difficult time we've had in emergency care in Scotland in a generation. And previously unheard of figures such as 12-hour waits are now a daily occurrence in many departments around the country. We know that these long waits in emergency departments are associated with patient harm, and what's more difficult to quantify is the moral injury to our staff who are having to care for patients for very protracted periods of time in unsatisfactory circumstances. This is certainly the most difficult time I've ever seen in emergency medicine.
I suppose if people are pitching up at A&E, they're probably worried about the length of time that they're going to have to wait. But is it not better that somebody sits in A&E for 12 hours than tries to manage at home if it's a dangerous injury?
And that is a concern. We are worried about some of the patients who maybe don't access healthcare because of fear of initially COVID during the pandemic, but now often it's a fear of having to wait for a protracted period in the emergency department. We've got a very good relationship with NHS 24 and 111, and we know that patients who can access the healthcare in other ways do try and access that via their GPs and via NHS 24. Unfortunately, every system is extremely busy just now. And many of the patients who come to the ED and have to wait for such long periods aren't those who can access healthcare in any other way. These are patients, the frail, the vulnerable, the elderly. Many of them need an admission. Many who need admission to hospital, who are the ones who are spending the longest times in our emergency departments.
You and other doctors have been warning for months about this. Are the health boards listening? Is government listening?
Across the board, all health boards are listening, and it's not an easy problem to solve. We have regular interactions with the Scottish Government, with the Cabinet Secretary and many of our partners in health, such as the Royal College of General Practice, who are facing similar pressures. So this is something that everybody's working really hard to fix, but unfortunately many of these issues are not easily soluble. Delayed discharges are at their highest level, more than pre-pandemic, which means that access to inpatient beds for our patients who require to be admitted is very difficult when we're running at bed occupancies of 90 to 95% all of the time.
Because it's quite difficult for people out with the NHS to sort of get their heads around whereabouts in the system the problem is. So is it actually that there's a lack of staff or a lack of beds in A&Es, or is it further on down the system that's causing the logjam?
It's a combination of factors that call what's called exit blocks. So we have difficulty getting patients out of emergency departments into inpatient beds because of a lack of capacity. There has been a slow reduction in acute bed capacity in Scotland over the last 10 years. Unfortunately, that pressure then washes down into assessment units and emergency departments, where we do have some staffing issues long and short term. So we in RCEM have been calling for an expansion of our staffing, but that's not something that's easily fixed. A consultant in emergency medicine takes 6 or 7 years after foundation years to train, so that's not easy to do. We also have the experience of our nursing staff being dwindled by, at times, having half of the number of nurses working in emergency departments that there should be on particular shifts. That pressure then washes down into the likes of the ambulance service, who have sometimes very prolonged waits outside emergency departments to offload their patients to us.
I know that this has been a long-standing issue for you, and it's not all COVID related. How now is COVID impacting on you? Is it staff? Is it more people coming into hospital with COVID related issues? How is it impacting? Because the numbers in the community seem to be dropping.
The numbers in the community seem to be dropping with the limitations of the testing process now, but we are still seeing numbers of staff absent, both short-term and medium-term, with COVID-related illness and with asymptomatic illness as well. We are seeing probably more patients with COVID rather than in hospital because of COVID, but that causes problems in of itself, where we don't want to have patients who have COVID and non-COVID patients who are often vulnerable in the same clinical areas. It also just means things like operations can't happen as quickly if they have COVID. Because
there's no community testing now, are you testing people as they arrive at the front door?
So many departments screen patients in the ED and do point-of-care testing for COVID for patients who are being admitted to hospital. We still don't test patients who are well enough for discharge unless they're coming back for planned operative surgical type procedures. So it's not that we are testing people for COVID when the present to the emergency department for all things, we are still testing them when they're being admitted to make sure that patients who have COVID are managed in the same areas and that we don't have those vulnerable patients managed in potentially risky areas for them.
And the Scottish Government, we heard yesterday, says that they've recruited a further 1,000 additional support staff to help. Will that make a difference when they arrive?
It will help to mitigate some of the risk that we've got just now of some departments reporting and friends, members of the college, fellows of the college reporting difficulty in some patients accessing basic nursing care and personal care needs. It will help with some of those things. It won't necessarily help in getting patients into the hospital any quicker, and it won't help with the long delays in ambulance offloading at times. So it's welcomed, but it's only a small way towards some solution.
John-Paul, thank you very much indeed for your time this morning. Dr. John-Paul Loughrey there, Vice-Chair of the Royal College of Emergency Medicine in Scotland.
We're talking about the return to the office this morning.